My name is Amrita Krishnan. I'm the director of the Judy and Bernard Briskin Center for Myeloma at the City of Hope Cancer Center in Duarte, California, and also now in Irvine, California. Today, I'm going to be talking about BCMA targeting and some of the new therapies we have available in advanced myeloma that target BCMA. Starting first with some basics, what is BCMA? So BCMA stands for B-cell maturation antigen, and it's a cell surface protein that's expressed on late stage B cells, but also importantly for the context of today, on malignant plasma cells. And binding to BCMA then sets off a whole chain of events in the plasma cell that lead to plasma cell proliferation. Now, therefore, targeting BCMA will lead to plasma cell death. And we now have a multitude of options available using this strategy. The first option that was actually the first FDA-approved antibody drug conjugate in multiple myeloma was a drug called Belantamab mafodotin. And as I mentioned, this is targeting BCMA, but it's an antibody that is linked to a cytotoxic agent, MMAF, a highly potent auristatin that leads to microtubule disruption and subsequently cell death. Now, this was a drug that was approved for patients with relapsed refractory myeloma after 4 or more prior therapies that include what we think of as the standard myeloma therapy: an anti-CD38 monoclonal antibody, a proteasome inhibitor, and an immunomodulatory agent. You can see here on this slide the dosing and schedule of the drug. It's a 2.5 milligram per kilo IV dose given every 3 weeks at a 30-minute infusion. And we'll get a little bit into the specifics of it, notably that it's only available through a REMS program due to the ocular toxicity that I will spend a little bit time talking about more because it is something sort of unique for us in the myeloma space. First of all, just in terms of the efficacy of the drug and why it was approved. So it was approved based on the phase 2 DREAM study, which was patients relapsed refractory myeloma. And these were patients with very advanced myeloma. And you can see here in the overall response rate, while it didn't seem like a home run, at the point that Belantamab was approved, the response rate of 31% for these patients really represented an unmet need. And so it did get approval. And you could see we even did see some deep responses, with about 11% of patients getting a very good partial response and about 5% getting a complete response. PFS still remains a challenge at 2.8 months, but duration of response was promising at 11 months. Now, on the right side of this slide, you can see the side effect profile, and I'm going to key in on the keratopathy, which you see in 71% of patients, and decreased visual acuity that we see in 53% of patients. So really, ocular toxicity is the main challenge with this drug. The other toxicities I think many of us in the myeloma space are familiar with in terms of antibodies, certainly pyrexia. Fatigue is really common to every myeloma drug, and infections in the advanced myeloma setting, very common to get respiratory infections. Now let's talk about keratopathy. So keratopathy occurs on the cornea, and it's important to know that it can occur with or without symptoms. Even patients who have fairly severe keratopathy may or may not have symptoms because it really depends where in the cornea this occurs. Meaning, for example, if it occurs on the periphery of your eye, you may not notice it as much as if it occurs really in the center. And usually with Belantamab, it tends to start at the periphery, in fact. And that may be, in fact, why 82% of patients didn't have a clinically significant visual acuity change. Now, we do have dose guidelines for keratopathy, and this is probably one of the most important things that we need to follow, and it's one of the things that is very common and ultimately leads to dose reductions in patients. And you can see here that patients undergo a corneal exam, which I'll speak to, by their eye doctor, and then they're graded, basically grade 1 to grade 4 in terms of their corneal exam, also graded in terms of their visual acuity, again, grade 1 to grade 4, based on the Snellen eye chart. Then you, as the oncologist, take the worst grade and the worst eye and make a decision in regards to dosing changes. So the eye care professional will give you the grade, and then you make a decision, as you can see here on the right, in terms of the dose modifications. Now, therefore, in part, since we are relying so closely on our eye care professional, this drug needs to be given in coordination with them. And so patients need a baseline eye exam within 3 weeks prior to the first dose of belantamab. And then they need a follow-up exam at least 1 week after the prior dose and within 2 weeks prior to the next dose. And then you get an eye care form from the eye care professional with that grading that we've discussed, and you use that when you see the patient in clinic to make your dose modifications as needed. The other things that we advise patients to do in terms of mitigating risk of ocular toxicity is to use preservative-free lubricant eye drops up 4 or more times a day during the treatment. And we actually, in our practice, we start at 24 hours prior to the start of belantamab. Patients are instructed to avoid the use of contact lenses unless specifically instructed by their eye care professional. And they're also counseled about the risks of changes in visual acuity in regards to a caution while driving and operating heavy machinery. Now, one of the challenges, obviously, in patients with advanced refractory disease is if a drug is working, they're very reluctant to stop it, even if they are having clinical symptoms. And so we do have some later data that's been published by Dr. Loniel and colleagues looking at what happens to patients who've required dose delays, even prolonged dose delays while on trial. And you can see that patients, fortunately, the majority of them can still maintain their response. 88% continue to experience a clinical benefit from the drug, and some of them, in fact, continue to deepen their response. And that likely is in part given the long half-life of antibodies in the patient. So I think that's something that can be reassuring to patients, that even if we have to hold dose, that they can still maintain response during that period while they have improvement in their ocular toxicity. Now, certainly, obviously, the way myeloma works is that you don't generally just stop with a single agent drug, and often we use that drug, therefore, in study in combination. And I show you here the Algonquin study, which then took belantamab in somewhat earlier lines of therapy and combined it with pomalidomide. And these, again, were patients with relapsed refractory myeloma, in this case, 1 or more prior lines of therapy, lenalidomide refractory, pomalidomide naive, which is an important point as well. You can see here 2 different doses of belantamab were studied in combination with standard dose pomalidomide. These were, again, relatively young patients, median age of 64, which is common in sort of in our myeloma studies. About 25% of them had had a prior autologous transplant. And as per definition, had to be len refractory. About 27% were also PI refractory. The response rates appear promising with this combination as shown here, including, again, caution, this is a very small number of patients. The IMiD PI Dara refractory group, 11 patients, but had a response rate of 100%. And overall, the response rate here in the high 80% range was promising for these patients. Again, small numbers of patients, but certainly a signal suggesting that belantamab can be combined with pomalidomide, and you can see relatively high response rates and a reasonable progression-free survival. Again, short follow-up, but nonetheless suggests that this may be a combination that we see more and more moving forward. And here you can see, just based on dosing schedules, again, PFS based on the 1.9 versus the 2.5 milligrams per kilo dose. I should also point out depth of response, including complete remissions, were seen in a group of these patients. And PFS, in fact, not reached in the 2.5 milligram per kilo cohort. Now, of course, the story doesn't end there, and I want to speak to the next class of drugs, not yet approved, but we're hoping for the first one in this class to be approved later this year, and that's the bispecific antibodies. And our center has done quite a bit of work in them, and really they represent an incredibly exciting step forward for us in the multiple myeloma world. And certainly you can see we don't suffer from a lack of BCMA-directed bispecific antibodies. And they've listed all the ones that are in trial right now, with the top two, teclistamab and elranatamab, being the ones furthest ahead because they're both now currently in phase 3 trials. And we hope to have approval of at least teclistamab later this year. Now, how do they work? So, as I said, they are bispecific, meaning they have two targets. Um, and not surprisingly, given to the topic of today, one of them is targeting BCMA, but the other is targeting the T cell, so CD3, and redirecting T cells towards the myeloma cell to further augment myeloma cell kill and T cell activation, continuing to contribute to basically maintaining remission in these patients. I'm going to talk a little bit about the trial that of teclistamab, the Majestic-1 trial that identified the RP2D dose for teclistamab monotherapy, as well as some of the phase 2 data. So here we can see here the Majestic-1 teclistamab monotherapy. You can see on the lower left of the screen the dosing schedule, and this is very common with bispecifics, that they're given with these step-up doses. So 2 small doses first, and that's generally to mitigate the risk of cytokine release before you get to the full dose. And that is somewhat of a challenge, to be honest, in advanced patients. And part of the work moving forward has been a way to try and shorten the time between step-up dosing, because obviously patients have very aggressive disease, and you really want to try to get to that full dose as quickly as you can while maintaining safety. Now, the Majestic-1 criteria, again, usual relapse refractory, intolerant, or refractory to established therapies. The other important part of this trial was no prior BCMA-targeted therapy was allowed in the original study. And why are we so excited about this drug? Because of their overall response rate of 62% in this heavily pretreated group of patients. And not just overall response rate, but depth of response, with 21% of patients getting a stringent complete remission and over 50% of patients getting a VGPR or better. Now, the original follow-up from Majestic-1 was relatively short when it was presented at 7.8 months, but the 9-month PFS appeared promising at 58.5%. So what this suggests is that bispecifics in myeloma can get deep responses, and these responses do appear durable as well. As I mentioned earlier, the original trial did not allow prior BCMA-targeted therapy, but obviously that doesn't represent the reality of myeloma in 2022. And in fact, patients are often going to get sequence therapy, and part of those prior therapies may in fact be BCMA-directed. I told you earlier, Belantamab was the first BCMA-directed therapy approved in myeloma. So, what happens if you relapse after Belantamab or after CAR T cells that we're going to talk about a little bit later? So, Majestic-1 had a later cohort C, that was specifically for patients who had prior BCMA-targeted treatment. And you can see here that we still saw responses in those patients of over 50%. And you can see on the lower hand, the swimmer's plot also suggesting durability of some of those responses. Now, in terms of safety, not surprising, in a heavily pretreated myeloma population, we saw hematologic toxicity, neutropenia in 65% of patients, and thrombocytopenia in about 38% of patients. I wanted to speak more to the CRS, which is something that is very expected in any type of T-cell engaging therapy. And we did see cytokine release syndrome in 71% of patients, but generally grade 1 or grade 2. So if mild cytokine release, only one patient had grade 3 cytokine release. The other thing in terms of what we wanted to speak to, though, in regards to bispecifics in general, that we're recognizing more and more is the infection risk. And indeed, when you look here in terms of COVID-19, there were 7 deaths in the original study due to COVID-19, 1 due to pneumonia. So really raising for us the concern about what we can do to mitigate and minimize infectious risks. And you can see 72% of patients had hypogammaglobulinemia. So certainly we have been using a lot of immunoglobulin supplementation as a way to try and mitigate some of this risk, at least against bacterial infections. Now, I did say that there is another bispecific that's already moved into phase 3, Belantamab, and I'm showing you here the Magnetism 1 trial against a similar idea, priming doses followed by the full dose. Here, though, you can see they use a single priming dose in contrast to some of the other bispecifics. Follow-up here now is about 10 months, and a response rate very similar to teclistamab, about 64%. And same idea here, depth of response, complete response are higher in 35% of patients, including MRD negative responses. And they also looked at a prior BCMA-directed cohort, and they could see, again, very similar to teclistamab, 54% of overall response rate in patients with prior BCMA-directed therapy. On the right, you see the swimmer's plot, and again, you can see that these responses do appear durable. And just to kind of complete the picture, show you some of the other ones that are a little bit earlier out here, and mechanism of action, and their phase 1 trial. You can see here response rate 75%. And 58% VGPR or better, including MRD negative CRs in this group of patients. Now I'm going to switch gears a little bit and talk about the other option for us now. So we're lucky in myeloma now. We went from one BCMA-directed therapeutic option and to these other ones. We now have 2 BCMA-directed CAR T cells that are approved, idacaptogene viclucel and ciltacabtagene autoleucel. And let's talk a little bit about them and some of the studies. So the first one, ida-cel, is our sort of nickname for it. You can see here, based on the KarMMa-1 registration study. And I have to put my glasses on for this. Sorry, I can't. This is way too small for me to see otherwise. So you can see, really looking at the active dose levels, which were 300 million and higher, you can see a response rate of up to 82% with the ida-cel. I think first I'll just look at the top of this and see the schema of how CAR T cells work. And that's important when you make a decision for your patients. Are you going to give them Belantamab? Are you going to give them teclistamab when it's available? Or are you going to try and get them to a CAR T center? Because CAR T does take a little bit more coordination as well as time, because patients have to be referred to their CAR T center. They have to undergo leukapheresis, so collection of their T cells. Those cells then need to be sent for manufacturing, and that manufacturing time is generally now taking anywhere from 4 to 6 weeks before patients can actually be treated with the CAR T cells. So often patients, and it's certainly in this study as well, they received bridging chemotherapy as a way to try and stabilize disease before they got their CAR T cells. Now, the CAR T cells themselves are given after chemo, usually fludarabine and Cytoxan, which is what we call lymphodepleting chemotherapy. It's a way to therefore allow you to infuse T cells and not have them immediately destroyed by the body. And then it takes about anywhere from, depending on the CAR T product, about 7 days for those CAR T cells to really expand in the body. Now, why were we so excited about CAR T cells? Well, we're really excited because, again, advanced refractory disease to get response rates of 80% and complete responses in almost 40% of patients was unheard of at any time before in our myeloma history. The challenge really, though, still remains maintaining those responses, and you can see that the median PFS is about 12 months. Obviously, longer in patients who achieved a CR. Median PFS there of 20 months. So a lot of the work moving forward is not just in terms of optimizing cell dose, but also trying to further improve upon this median PFS for patients post-CAR T infusion. Some of the things we looked at as we got more and more patients is, can you give this to older patients? And you can see here some further long-term follow-up data in patients over the age of 65. It looks like survival is very similar. Challenging group of patients for us has been patients with extramedullary disease, and can they respond? Yes. You can see here, though, still patients with RISS3 still remain a very challenging group of patients, with that median PFS still being a little bit less than a year. If you look at it in comparison to real world experience, because we obviously have no data presented yet in terms of the phase 3 trial with ide-cel, though we are awaiting that. We have indirect comparisons with real world databases, and you can suggesting, again, improvement in OS compared to real world available standard of care therapies. Now we have another CAR T cell approved as well, so very exciting for us in the myeloma world. We have a second choice, and this is a cilta-cel based on the CARTITUDE-1 registration study. Again, advanced disease, 3 or more prior lines of therapy, triple class and CD38 antibody exposed. We have fairly long follow-up now, and unprecedented response rates of 98%. Not just that, depth of response, VGPR, are better in 95% of patients, which is incredible. You can look here in terms of median PFS. Here, very exciting. The median PFS has not been reached, and 2-year OS of 74%. So really a huge step forward for us in terms of our patients with advanced multiple myeloma. Again, real world comparisons, and you can see here, based on the locomotion study compared to standard of care, not surprisingly, markedly improvement PFS and OS compared to standard of care options from real world databases. And here is the updated PFS and OS curves from the CARTITUDE-1 study, and you can still see that this OS curve looks pretty incredible at 70%, and the median OS, in fact, not reached. Now, having said that, though, the challenges really are not. No one argues that these are effective therapies. It's really been access to therapy that has been a challenge for myeloma doctors. Every myeloma CAR T center has long waiting lists of patients to get these products, and we have limited spots allocated to each center. So I think for us, that has really been the biggest challenge, is not the efficacy of the therapy, but it's about getting that therapy to patients. Certainly, when you have such effective therapies, the interest is in terms of moving them earlier. And part of the rationale is, earlier in the course of myeloma, T cell fitness may be better. And so that may further improve some of the challenges in regards to progression-free survival, because of persistence of these T cells. And you can see here a multitude of studies, including in high-risk newly diagnosed disease, in patients newly diagnosed who transplant not being considered. And the one that I'm actually most interested in as a transplanter is CARTITUDE-6, which is going to compare cilta-cel to autologous stem cell transplant in a randomized controlled study. So very similar to what our lymphoma colleagues have already done. We do have some data already in terms of cilta-cel in earlier lines of therapy. The CARTITUDE-2 study, patients had 1 to 3 prior lines of therapy. Caution, again, very small numbers of patients, 20 in that cohort A. Cohort B were patients who had an early relapse. So a high-risk group of patients, if you relapse within 12 months of your first line of therapy. Again, small numbers, short follow-up, but you can see the response rates very, very high. That's not surprising. I think what we're really waiting to see really still is the durability. And so far, the 15-month PFS, 70% median duration of response not reached. So, we continue to await further follow-up. Right now, the median follow-up 17 months. We're going to, continue to follow these patients and be interested in terms of the durability of those responses. And similar here in terms of the median 13-month follow-up, seems to be that we are seeing that in the swimmer's plot that these responses do appear to be maintained with the 12-month PFS right now almost 90%. And I mentioned to you, yet we don't have phase 3 data yet. We have a press release, though, which is sort of how often things get disseminated first. And we're going to await the actual trial data, hopefully at one of the upcoming meetings. So the press release on KarMMa-3, the phase 3 study looking at ide-cel compared to standard regimens in patients who'd relapsed after 2 to 4 prior lines of therapy. And we know that based on the press release that we saw a pre-specified interim analysis was met in terms of improvement in progression-free survival in patients who received the CAR T product. Also improvement in the secondary endpoints of overall response rate compared to the standard regimen. One caveat is the overall survival endpoint is still ongoing. But I think we are very excited. This is our first phase 3 results from our myeloma CAR T products.
Could I just clarify this? The KarMMa-3 trial, what prior therapies were they allowed to have? I'm trying to figure out how early it was.
Yeah, I mean, it's 2 to 4 prior lines, so it's probably like transplant and then one other line of therapy, right? Is generally what it's
One
going to
line, yeah.
be.
So sort of third
So,
line. Okay, that's pretty early.
yeah,
Okay,
exactly.
great. Awesome, great.
Okay, so in regards to toxicity of CAR T cells, similar to what we see in terms of toxicity with the bispecifics. Again, anytime you engage T cells, you're going to get cytokine release. It is a little bit different in CAR T versus bispecifics, though, in terms of, first of all, onset of cytokine release. So, interestingly, ide-cel, the median time to onset of CRS is 2 days. Cilta-cel, it's 7 days, and that has to do with how timing of the T cell expansion within the patient. You also see neurologic toxicity, and this is something that is certainly bears watching. And about a third of patients in ide-cel develop neurologic toxicity of any grade ICANS. And similarly with cilta-cel, about 21%, and 10% had grade 3 or higher. So a lot of work's being done now in terms of how do you reduce that neurologic toxicity? Is it better bridging chemotherapy? Obviously, patient selection is something we're looking at as well. Who is at more risk for getting neurologic toxicity? Because that tends to be the hardest thing to manage for us with these patients.